bleeding, less pain, and smaller scars. You might remember that first laparoscopic nephrectomy was published back in 1991. To be honest with you, the first robotic operation on the prostate was performed. Before that, I will show you the video, but over the years, what we have realized, what are the disadvantages of laparoscopic surgery? Number one, the surgeons have to rely on assistance for camera control. Movements of the instruments are counterintuitive. That is, the movements at the tip of the instrument is the opposite direction to what you are trying to do. Laparoscopic surgery causes more mental fatigue and musculoskeletal problems. And as a consequence, almost 90% of the surgeons, when they reach their 50s, they suffer from occupational injuries. And therefore, although laparoscopic surgery is very attractive, it is not an ideal alternative to open operations. The historical reality is that robotic prostate surgery was performed before the first laparoscopic nephrectomy in Guy's Hospital in London in 1981. And it made the international headlines at that time.
Robots. It must be tomorrow's world. World. Tonight, our world's first. How would you like to be operated on by a robot?
In a London operating theatre, the doctors are standing back and allowing a machine to do the work. For the very first time, a robot is wielding the knife and performing surgery on a human being. But next, the image of robots performing surgery on humans is so futuristic that it appears every week in the opening title. This vision of the future is really happening. The unique operation on the prostate gland is being performed by a robotic surgeon. James Younger reports on this world first.
This team of surgeons from Guy's Hospital and engineers from London's Imperial College are making the final adjustments to the machine at the center of a radically new form of medicine, robot surgery. This is the first robot in the world that's capable of surgically removing tissue from the human body. In a few moments, it's going to perform a highly skilled operation, completely unaided. The surgery is to correct a problem that plagues the lives of millions of older men, enlargement of the prostate gland. The gland lies down below the bladder. When it swells up, it presses on the tube delivering urine from the bladder, which makes it difficult to urinate. Sufferers constantly have the urge to use the toilet, but when they get there, they just can't go. Each year in Britain, about 40,000 men undergo a fairly standard operation to clear the blockage. But today, the operation is anything but standard. It will be performed not by humans, but by the world's first robotic surgeon. Albert Friend is one of its first patients.
This operation can be easily adapted for a robot to do it because it requires constant mechanical repetitive actions. And one of the main functions of a robot is to repeat the actions again and again, accurately and more precisely than the human hand.
This incredible piece of machinery is capable, without human help, of removing lumps of tissue from the prostate gland. Its automatic arm will travel right down the center of the penis to reach its target. And the robot won't use anything as crude as a knife to cut through the gland. Instead, it will use an ingenious new device, a minute electric roller which will vaporize the prostate gland's tissue. The robotic surgeon is now almost ready to start removing part of Albert's prostate gland. But before it's left to operate on its own, the human helper has got to tell it where to cut. By using an ultrasound probe, the human surgeon is able to see exactly how enlarged the prostate has become. You can just see it on this screen. It's the dark grey area around the center. To give the robot its instructions, all the surgeon has to do is mark the areas causing the blockage. The robot now has a precise three-dimensional model of the tissue that has to be removed. Ivan?
So this was back in 1989, and the robot was called Probot. What happened then? About 17 years later, the Computer Motion was a company in the United States which launched Zeus robot in 1996. And using this robot, the surgeons performed a transatlantic cholecystectomy where surgeons were sitting in New York and United States, and the patient was in Strasbourg in France, and they did their first cholecystectomy. Then in 1999, Intuitive Surgical launched the Da Vinci robot, and Intuitive Surgical bought over Computer Motion in 2003. And that was the actually moment when Da Vinci, Intuitive Surgical became the sole manufacturer of the Da Vinci robot and dominated the world of robotics for almost 20 years until Cambridge Medical launched the robot in 2018, and subsequently the Medtronics launched the Hugo robot in 2019. At the moment, there are about 11 or 12 companies which manufacture surgical robots. So the question is why the surgeons fell into love with the Da Vinci robot. There were four main reasons which actually attracted the surgeons to switch from open or laparoscopic surgery to robotic surgery. So firstly, the 3D vision. There were 3 arms to do the operation, 7 degrees of freedom of movement, and more importantly, the movement of instruments inside the patient mirrored that of the master controls at the console. And that gave the minimally invasive surgery open surgery orientation. And more importantly, the surgeon can sit at the console very comfortably and do the operation. So ergonomically, the robotic surgery is much better than the laparoscopic surgery. Now, coming to robotic surgery in PKLI, is it possible? The natural reaction when you ask such a question, people will say everything is impossible unless it is done. But the team has demonstrated they have the will and they have the motivation to actually start the robotic program in PKLI. There are other centers who want to start the robotic program. There are 2 options. One is that they can join an existing program which avoids the initial investment. You can share the cost, running costs. It saves you the initial hard work, but you will not have the full control of the program. The other alternative for other centers is to start a new program. That means you will have to have more investment and you have to share the burden of running costs, but you have a complete control of the program. So if you are going to start a new program, the first and the foremost is you need to have a robust business plan. A robotic program will only be successful with a multi-specialty involvement and a high throughput. You should aim to have at least 400 to 500 cases a year. You will only achieve this by adhering to the principle of teamwork and collaboration with other specialties. Once you have the robust business plan, you need to acquire a system, need to ensure that there is supply of disposables, service contracts. Should the machine go, for example, bust, then you need to get it repaired. Need to have a robotic theater, and more importantly, identify and train the team. Minimally invasive surgery, like any other surgery, is a teamwork. Surgeon is the captain, anesthetist is your goalkeeper, robotic assistants and the theater nurses are your rest of the players. And when you play as a team, you win many World Cups and championships, as we have done in cricket in the past. But when you play as individuals, you will fail. If you are starting the robotic program, it can be challenging initially if there are multiple people who want to do the thing at the same time. It's a recipe for failure. What can we learn from others and our own past? I will share you the Guy's and St. Thomas's experience and then what happened in Pakistan. The Guy's and St. Thomas's, there are 3 hospitals. Guy's Hospital, which has departments of urology, renal and pancreatic transplantation, thoracic surgery, and ENT. These are the specialties which are using robots for surgical procedures. St. Thomas's, which is about 2 to 3 miles away from the Guy's, has upper GI, lower GI, gynecology, and plastics who are using a robot for the surgical procedures. And the Evelina Children's Hospital is next door to St. Thomas's Hospital, so they can share the robot. The first robot, the Da Vinci robot, we bought in 2004, and it was 1.2 million, and the money was actually given by the Guy's and St. Thomas's Hospital charities. So this was the team initially, which started the robotic program back in 2004. When we started the program, how others reacted. Most of the people initially will be very skeptic as to why you are doing this. Then they will cautiously accept it. And lastly, everybody develops the enthusiasm and they want to join the bandwagon. So in robotic surgery, we started with gynecology, lower GI surgery, upper GI, ENT, and thoracic. And currently we have 7 robots and 7 specialties doing robotic surgery. What is the volume? We did about 1,500 cases.
He's the one who started robotic in UK,
2022. So robotic surgery in Pakistan, what happened in Pakistan? The first robot was bought in 2011 in Qatar, Karachi. It did about 200 cases. Please forgive me if the figures are not correct. And then Da Vinci SI came in civil hospital, which is will be phased out in 2023. We did about 25 cases over 4 years. The urology team was allowed to join the robotic program in June 2017. We did about 800 procedures between 2017 and 2020 when, unfortunately, COVID interrupted everything. The second phase, which is now, I'm very optimistic that hopefully this will be more successful. There are about 7 systems around the country, 4 in Sindh, one in Lahore in the private sector, and hopefully 2 coming to PKLI in Lahore. As you all know, that Intuitive Surgical has put a ban on the business with Pakistan. These are the people who actually initiated and contributed to robotic surgery in Pakistan. Where is PKLI today? You have the hopefully business plan in place. You have the finances approved, systems ordered. Urologists have gone for training. Liver, renal, and theater teams need to be trained, and you can start with the urology, liver, and then renal transplant programs, and success will be yours. I would suggest that you go for a stage program, start with urology, nephrectomies, prostatectomies, cystectomies, and reconstructive surgery. Then start with the liver, cholecystectomies, tumor resections, and donors. And lastly, with native donor nephrectomies, and robotic transplant. Most importantly, what I would suggest to you, that you must maintain a robust database and audit your results. Why? Because outcomes are surgeon-specific, not techno-specific. A fool with a tool is still a fool. And as a responsible body of surgeons, we must justify our actions to the nation which is drowning in poverty. Long-term challenges you will face, and you must start thinking about it, how you're going to face those. Firstly, single site and limited specialties. Do we have enough volume in-house for a successful program? And can you possibly invite and welcome surgeons from other centers to bring their patients and operate in PKLI after proper training? What is the secret of your success? We must make pledge that we can do it. We will do it together, and we will audit our outcomes with honesty. This is the message our founder gave us about 72 years ago, and we must stick to these principles. And I wish you very best in your robotic program. And thank you very much for listening. Happy to answer any questions if you want to do it now or later on. That's it.
The programs forward, not only in the UK, you've also been mentoring the robotic programs in Pakistan, including SIUT. So we really appreciate your efforts, and thank you, and thank you for your presentation. I think because we're short of time, I'll take any questions from any audience.
Yes.
Please.
I just the figures given by Professor Shamim regarding gynecology. I'm a gynecologist, Professor Samia Malik. In year 22, 80 something, the figure was given, gynecological surgeries had been performed. I just wanted to know, isn't it very common to perform gynecological surgeries in UK with the robot?
To be honest with you, I think open surgery is almost extinct. I think there are a large number of cases of gynecological surgeries are being done with a robot. There is a robot in St. Thomas's, and gynecologists are doing it. I think maybe in 5 years, almost over 90% of the procedure in all specialties, irrespective what specialty you're practicing, will be done robotic. So robotic surgery, yes, we are doing benign hysterectomies, malignant hysterectomies. Urology, over 90% cases at the moment are robotic. And likewise in thoracic, they are the second largest actually specialty which are using the robots. ENT, plastics, and lower GI, upper GI, everybody is going towards robotics now.
Thank you very much, and I thank you for your presentation, Professor Shamim. The next speaker speaker is, as we all know, that once you get an equipment, once you have established a service in the field of surgery, we all know that there is a fact which is called the learning curve. So I requested our next speaker, Professor Matin Sharif. So Professor Sharif, can you hear me, please?
I can indeed. Assalamu alaikum.
And Assalamu alaikum, and thank you very much. And I really apologize for keep you waiting for your talk. We are just running behind from the schedule, but I really appreciate yourself and that's fine. And over to you, sir. Please go ahead, and thank you very much again.
Okay, thank you very much. Let me just get myself organized here. Okay, you should be able to see the screen now.
Yes, we can see the screen.
Okay, so I've been asked to talk about robotic surgery learning curve. This is, of course, important for any surgical skill, whether it's open, laparoscopic, or robotic. I think we've all heard an action talk earlier on from Shamim. And one thing which is well established over the last 20 to 30 years, we have had a silent revolution where we moved away from the left of the screen to the right towards minimally invasive surgery because of better results in experienced hands. And that's the key thing, in experienced hands, in the hands of people who have gone through the learning curve. Laparoscopic surgery, however, you also heard earlier on, is technically challenging. It's because counterintuitive. It's physically very demanding. It really is surgery for the young. And as you get older, because of the mental and physical demand, it actually becomes quite difficult to keep up with the pace. It has a longer learning curve. The typical learning curve, as you see at the bottom of the screen, is a sigmoid shape curve where you're slow at the beginning, and then you have a steep acceleration, and then you actually plateau off in your learning curve. For laparoscopic, it's actually quite a slow learning curve with what's to refer to as quite a steep rise compared to particularly robotic surgery. Now, you've just heard there are well over 12 systems worldwide which are now available. The dominant one remains the Da Vinci Xi. There are over about 6,500 of these systems currently available in the market. They are truly the world leaders, not only just in terms of providing the machine, but also in terms of teaching and training. Now, CMR Versus is, of course, now available in Pakistan. Intuitive they put a moratorium because of their rather unfortunate experience at the beginning of the introduction in Karachi. Others are now coming in, particularly Medtronic. And Medtronic, I believe, I've been in discussion with them very recently.
Professor Mehta, sorry to interrupt. Your slides are not moving, so we are stuck to the first slide, basically.
Okay, I'm not sure what's happened there.
Okay, slides are moving on your side? Are you?
They are moving on my side, definitely.
So can you move to the next slide?
So what can you see at the moment?
I can see the key message.
Well, that's really towards the end. Let's start at the beginning. Can you see this?
No,
सर ये
no.
उनका सिस्टम स्टक हुआ है
हाँ?
उनकी साइड से सिस्टम स्टक हुआ है क्योंकि एरो देखिए वो बिजी जा रहा है
Can you so
Restart them.
probably you'll have to stop sharing and then restart it?
उनकी साइड से
जी.
ये भी है
It's from their side.
not responding well.
So what would you like me to do?
क्या करना है?
पीपीटी की जो स्लाइड है वो एक मिनट बंद करके दोबारा करना है
बताओ ना क्या
Let me stop sharing. Okay, and start again then.
Yeah, exactly.
Okay, so I'm going to reshare. And let's see.
Gee, now we can see it.
Okay, now.
Yeah.
Please try to move the next slide.
Okay, can you see the first slide?
Yeah, exactly. Now it's moving.
Can you see the second with the pictures? MIS benefits.
Yeah, we are seeing your third slide. If you move to the fourth, so we'll.
You need
What
to
do you
put
see
it in
now?
presentation mode, and that's why the slides are not moving.
Okay, what are you seeing now?
You need to put it in presentation mode.
Please close the PPT and try again, restart the PPTs.
Okay, I'm going to end the show again. I'm going to stop sharing. Okay, let's start again.
So, yeah, we can see your first slide. I think leave it like this, and if you
Okay,
now we
can
can
you
see your
see?
slide
Yeah.
moving. So
Now it is
whatever it
moving.
is, just leave it like that, and let's continue with the lecture.
Okay, okay, all right. So
We can
where
see your
was I? I think, can you see this laparoscopic surgery problems?
yeah.
Yes, we can.
Okay, so let's move on to the robotic surgical systems. I think this is where I was.
Yeah, exactly.
You heard earlier on from Shamim as well, there's about 11, 12 of these systems currently in Pakistan, and we know it's only Versius. But I can tell you, hot off the plate, Medtronic are very keen on entering the Pakistan market. I've been in discussion with the regional director. And in fact, we've got another meeting next week after the bank holiday. And if you guys haven't quite put an order in, you may want to think about Medtronic. Medtronic will definitely be a superior system to the Versius. I think once the dust settles, you will have two systems in the market. You will have the Da Vinci, without any doubt, the XI, which if it was available, that would be the best system for you to have in Pakistan, without any doubt. If that system is not available, it won't be for the foreseeable future. Then you're looking at the next best system is Medtronic because of the instrumentation. CMI is limited because they do not have robotic instrumentation such as the Hemolock, the stapler, the vessel sealer. And the Indians have come up with a system too called the SSI Mantra, which you'll see right at the bottom there on the right-hand side. This has just started. I don't know what the experience is at the moment. Let me tell you about my own journey, which has been from open through across to laparoscopic and then robotic. When I was appointed back in 2000, I didn't have any experience with laparoscopic or robotic surgery. I was doing mostly cancer with reconstruction, open prostatectomies, cystectomies, nephrectomies, etc. Within 4 years, I had the privilege of setting up one of the highest volume laparoscopic regional service in Kent, linked to some of the other hospitals in that area. And for the last about 6 years, we've had the privilege of having a very high volume of robotic service. And as a result of this, there are certain key things which I think are essential in minimizing your learning curve and ensuring that you continue to have a successful MIS program. The first thing is, what are your goals? Your goals are going to be very clear, and they have to be that you want to provide the highest quality care, gold standard for your patients. And that actually means that you have to be continuously learning. It doesn't mean you just learn at the beginning and that's it. You already heard from Shamim, it has to be a multi-specialty program. If it's not multi-specialty, unless you've got very high volume cases from within one specialty, and it may be that at PKLI, you will have high enough numbers from urology, perhaps from hepatobiliary, not to worry about anybody else. But multi-specialty is the key. Now, approved training programs is the key to success. And I'll come back to this a bit later. You already heard that this is a team support. That means the weakest link in your team will actually end up determining your outcomes. So you have to ensure that everybody is well trained, including the first assistants. I would walk away from using registrars as your assistants, and I would seriously look at technicians that you should train up as your first or what's called bedside assistants. And the ergonomics is very important. In other words, the layout in theater, the space has to be optimal. You can't do this in a small, cramped up theater. There are plenty of publications that suggest that you will not have as good outcomes. The number of cases is important. You heard that early. And the caseload has to continue to be sufficient. So if you're looking at doing prostates, the NHS England suggests that you should do at least 25 of these a year and at least 100 as a center. If it's cystectomy, it's about 15 minimum a year and at least 30 a center. You need to have high quality equipment, and that means dual console. Without a dual console, you cannot seriously train anybody. And even with this open console that the Versius offers, it's not good enough. You really need a dual console so that you can be sitting there training the other person, taking over at the optimal moment. And you should have an air seal. Air seal is a new insufflator system that allows you to operate on a very low volume, very small pressures to reduce the cardiovascular side effects. Regular ordinary learning, you heard earlier, absolutely important. You need to prospectively collect data, and you have to have the mindset that one day you will be training other people. In other words, you'll be producing proctors, mentors will go and teach what you've learned to others, because that is also part of the learning for yourself. All of this is well established, and there are a number of key publications which I've outlined at the bottom of this slide, including the one from Guy's, another one from Naim Somro, and one from colorectal and general surgery, and that's Muller et al. All of them suggest the same thing. They've looked at multi-specialty practice, as you've seen here. They've actually looked at certain learning curve metrics, not only the operating time, not only the time spent on the console, the setup time. They looked at complications, the length of stay, and they've looked at the point at which you actually become, if you like, an expert or sufficient to be able to produce good quality outcome. Now that varies from case to case, from procedure to procedure, and it also depends on your own previous experience. So for laparoscopic surgery, it is definitely high numbers. For robotic, is comparably slower numbers, smaller numbers. And key thing that they all come up with is training. Training is the key to all of this. And training isn't just, as I said earlier, what happens at the beginning. It's continuous. It's continuous for the whole of the team. It's not just the technical skills that everybody knows about, but it's the non-technical skills too, the cognitive development that nobody really talks about, and actually is just as important. That's to do with right decision-making within a teamwork with clear line of communication in a bit like military precision, so that you have the desired outcomes. Otherwise, you're more likely to get complications, you're more likely to take longer and actually have more complications. So the training modules have been looked at throughout the world. Unfortunately, there's no standardization still. However, certainly in Europe, the BAUS, the British Association of Urological Surgeons, and the European Association of Urology modular training is the one which is now becoming increasingly well established. And it has certain steps to it which you have to go through, which include initially starting with online training. You can do that from sitting at home and just getting on and joining the e-learn training modules. Simulation. There is a direct relation with the time you spend on the simulator. A minimum of 20 hours is what's recommended before you move on to actually doing something in the theater itself. You know, be that dry lab, onto then obviously going on to live surgery, and then looking at specific procedures. So that is a very, very important part of your learning curve in order to reduce your learning curve. And then you're looking at fellowship, mini fellowships, as well as full-fledged fellowships, which should be modular, meaning that you break down the actual procedural steps and train people in the different steps of that operation. And then when the time is right, you allow them to do the whole operations. That minimizes the time that's been spent in theater, so that you don't have the time-related complications. Eventually, the individual needs to be certified through a recognized proctor, and then you're off to independent surgery. But it doesn't stop there. Once you've started independent practice, you need to continue to collect data, review your practice, and these are the key essential messages that I have to get through as I come towards the end of my talk. that it is the entire team that you have to focus on, not just the surgeon. And that concept is something which unfortunately is not well established in Pakistan. Everybody still thinks the most important person is a surgeon. Actually, surgeon happens to be the captain of the ship, as we heard earlier, but it's the entire team. And that means everybody, the anesthetists, who unfortunately are not usually given the time of the day in most of the hospitals around Pakistan, although there are exceptions to our rule, and that includes the PK line. Prospective data collection and auditing openly and transparently, discussing your complications at regular intervals so that you're reviewing your own practice. And once you think you're okay, you're off independent practice, you should go and visit other centers to see what you can learn to bring back to your own team to continuously improve your outcomes. So thank you very much. And I'm sorry about the technical hiccup that we had earlier.
Thank you very much, Professor Sharaf. I have no questions. I will leave it to the audience and our experts and our chief guests if they have any question or any comment to make on the learning curve of the robotics.
I think the essence of the two talks have been that it has to be a program, not just an episode or an operation or a tool. And then it makes sense if it is multidisciplinary, and it should have a high throughput. And finally, there should be an audit so that we can. So these things are, I think, the basis of that program.
Thank you very much.
I think in the training, looking at Pakistan, we need to have what Mr. Martin said was that in the training program, essential becomes your dry lab, your wet lab, and we don't have it established here. Working on the console, yes, consoles can become available, but when it comes to the other things to be trained, that we are lacking. The more we have it here, the more it would, and I would request CPSC, as the Varis Paluga is there, since they at least they can set up that for the training program so that we can move forward.
Nadeem, can I just pick up on that, please, if I may?
Yeah, please. Please.
I mean, I think the audience have got the message. I'm sorry, I didn't know the name of the very first person who spoke, but you summarized the message very well. The key thing here is it's not just getting a robot into your system. And Nadeem and others know that I've been going around Pakistan with a message that we need at least one center of excellence, teaching and training with the dry lab, wet lab, simulation in each of the provinces. That includes Lahore, it includes Sindh, of course, Punjab and other places. And the idea is that you should be looking at a fellowship. And we have been in discussion with the college to set up a fellowship in MIS that includes robotics as well as complex laparoscopic surgery. So I think the message is, it's not just about getting onto the robot and being able to do a few cases. You know, you have a responsibility towards teaching and training the future generation, and you can't do that unless you've got a proper training program set up. And I think PKLI is in a perfect position, all right, to be able to do that. And I look forward to their promise to set up a regional training center. Thank you.
Thank you very much for your comment and thanks for the questions. I think we will have to move on to the next topic, and I hope Professor Faisal Saldar was here because he was the one who was very curious about artificial intelligence in robotics or otherwise. So we have our next speaker, Professor Naveed Afzal from the UK, who is an expert on artificial intelligence and artificial intelligence in robotics. So over to you, Professor Afzal, and thank you very much for your time and your patience.
Thank you very much, Nadeem Saab. First of all, I'll congratulate you for organizing such a nice seminar workshop. Let's change the mood, you know. So we have heard some very serious talks. this is like I'm going step forward, and inshallah, I hope everything will be fine. You guys will be very established one day, and then you will be thinking of this next steps, how to improve on what you would be offering with robotic surgery. So let me see if I can share my slides. So, okay, share. Okay, so just give me 2 seconds. Share. Try. I'm having some problem, Adisa. If your technical staff can help me out, my PowerPoint slides, if you can go up. Okay.
शेयर अवेलेबल सर उनकी तरफ से हमारी तरफ से होता है
Yeah, they're coming through. They're coming through. Just 1 minute.
Okay, well.
Yeah, just give me a second. Can you see my first slide?
Yeah, we can see your first slide.
Right, okay, okay. Right. Let's see if we can. Fine. So I work in the UK in Dorchester, and let's see. Fine. This is my journey started. I happened to be in Stanford. I was doing my fellowship 1995, and by chance, that was the time when they were trialing this prototype robot in Stanford University along with Ministry of Defense. They wanted to create a machine where they can operate remotely in field hospitals in Iraq or Afghanistan. So it's just by chance I was there at the time, and I happened to see how this prototype was being evolved in Stanford labs. So then we come to, like, as I said, once you have got this established, inshallah, which will, then you are looking at a second phase, how you can adopt these other technologies to facilitate complex surgeries. So this artificial intelligence basically steps in when you are going into very complex surgeries, not that much needed for basic surgeries, which you can easily perform with conventional whatever you have available. I don't want to go in details of artificial intelligence, but there are two types. So the myth, I would say, what in artificial intelligence in robotics is that it is there to facilitate the surgeons. It's not to take over. The misconception is that artificial intelligence will come in, robots will take over, like we have seen in the movies, RoboCop, that eventually robots will take over from human. That's not the case. It's there to facilitate the surgeons, different technologies in there which can help you. So, and there was this talk from one of the gynecologists yesterday, I think it was Dr. Samia Malik, that people ask, oh, you are giving us to robots to operate. That's not the case. Robots don't take over. I mean, this is a kind of exceptional field where it's not like painting cars or doing other chores. Humans are different. So surgeons, humans are always going to be in charge to operate on humans. Look, we can't hand over it to the robots to do surgery. So there are new innovations in which can help. Again, I said for complex surgical procedures. So like Tile Pro, and in robot, we have got ultrasound scanning, which is introduced operatively to find out renal tumors. And then artificial intelligence plays part in remote telesurgery when the surgeons are not available to operate, but there were time will come where robots will be everywhere in Pakistan, and then you are helping out. You are sitting with your console somewhere in the center in PKLI, and you are helping another surgeon in Burewala or Jhelum or somewhere. A day will come, inshallah. So telesurgeries, your console, operating console, you are helping out with internet connection to another surgeon who is somewhere else in the country. And artificial intelligence help in intraoperative assistance. So we have got these camera controls, but the future artificial intelligence, because now we are even with the latest XI robot, we have to control, zoom in the camera with our foot and our finger grips. But the next thing is your eye movements will control and move the cameras. Wherever we want to look, you move your eyes, your corneas, and robot will pick, and then it will move the cameras accordingly. So you don't have to do anything. So that's, and then we have got this IDG guided, where you inject indocyanine green, and then eliminate site where you want to operate. They'll show you. Can everybody mute? I get some echo from people in the audience. I think online audience, they have to mute. And then you can do this IDG guided lymph node dissection. So the various things which can be done. They are just to facilitate you. So let's talk about them one by one. So what basically, as I said, this AI is just to facilitate. And indeed, what we can tell the robots, and then like calculators and computers, and they can, if we talk about future where more talks could be done with the robots, then things will come up with few, like these camera controls, some simpler talks like suturing, some other things will come, but that it will take some time before those things can develop. So moving on to, let's talk about things one by one. How this, like I said about ultrasound, how this is going to help you guys when you establish, how it's helping us here. The surgeons who are doing partial nephrectomies, then we know it's a difficult procedure and you need some help. So this intraoperative ultrasound is a very good tool where you can do perioperative ultrasound. During the surgery, you can demarcate the tumor margins, and then you can do a successful partial nephrectomy without leaving any positive margins. So there's a short video, if I can present there, it's a good one, but I'm not sure whether it will go. Okay. I'm having some difficulty putting this video on, but this is one of the BKs, this is for operative, is about the ninth video. How can it can help with delineating or demarcating the tumor, and then you can do a successful resection without leaving a positive margin. I think we can try this in the end again. Moving on. So this is the other thing, that you would be using your whatever method, whether you are using CMR versus we use XI here, we still have to use our hand console and our foot to zoom in, zoom out, and to move our camera. But this AI, that abdominal surgical can move by means of eye tracking camera. Surgeons are able to move the camera simply by moving their eyes. Your cornea will sense. There's a sensor will sense your eye movements and will move the camera. And this machine also provides haptic feedback, so they can feel the forces that robot arms encounters, so that if there's any obstruction or any tissue in front of the camera, you would know. So several other new technologies have come in. With this, like here you can see this image. So if you see from a naked eye, all you see is skin. But if you have your images, you have got your angiography, and that is superimposed on your screen when you are operating, then you can see where the bones are and where the blood vessels, where the nerves are. So when you are doing your surgery, then you are careful and you are not injuring those organs. So if we have got like a gynecologist in the audience, imagine if the nightmare for us when our gynecologist started surgery was that whenever they were doing complex hysterectomy, some with endometriosis, we always had worries that what is going to happen to the ureters. So imagine if with this you have got a CT urogram, and if you are looking at the screen and this can be superimposed on side of your screen, so you know exactly where the ureters are, then you are unlikely to damage the ureters if you're doing very complex surgery, your cancer surgery or endometriosis or hysterectomies. So this is an advantage. So all you need is a Tile Pro UCT urogram, and the software superimposes it on the screen. It's like when we do MRI fusion biopsies, and sometimes you're doing transperineal biopsies of the prostate, small lesion, pyrite 5, but you can't see it. So you are going around biopsying, but you can miss. But if you've got MRI fusion, it will tell you exactly on screen where the lesion is, pyrite 4, 5, and you can sample that particular spot without missing it. So that's the advantage. It things to help the surgeons. Going back. So this is AI, and this is augmented reality, where you can superimpose 3D models on anatomy of the patients. And this allows the surgeon to see beyond the hidden anatomy. So you will be able to see under the peritoneum where the relevant organs or structures are, especially for our gynae colleagues, they can see the ureters. So this is endoscopic view using Tile Pro, so intraoperative anatomy. I have been to this CMR facility in Cambridge, and we spent a day. We were invited there to see their manufacturing and research facility, and I specifically asked the question that whether that software can be introduced. So they're a bit far, but this is like future. I think Intuitives are a little bit more advanced in this Tile Pro and Firefly technology. So here you can see that see the anatomy and how during partial nephrectomies, if you can, it can be helped rather than your like 3D image, if there can be extra additional help to show you where the blood vessels are under the peritoneum, where the segmental renal artery. So that's going to facilitate the surgeons. Just going back once. Yeah, so this is basically partial nephrectomies. This augmented reality improves surgical strategy. So you can do higher selective clamping, and then you can ischemic time could be reduced by this technology. And then next one is regarding, I mainly do prostate surgery. So you can have reconstruction of your prostate, and if you know where the exactly the tumor is, and when you are doing your surgery and you are doing your nerve sparing, and if on screen you can be shown that that's your tumor. So if you're doing nerve sparing, then you know if the tumor is there, you can go a bit wider there on the left side, but the other side, on the right side where there's no tumor, you can do intrafacial nerve sparing without risking a positive margin. So just this additional little tools to facilitate the surgeons to accomplish their surgery. And I talked about IDG green, you can inject. And because if you're doing surgery and if you're supposedly want to take the lymph nodes, we all know that lymph nodes and fat looks very similar. And with very expert surgeon, even sometimes it's hard to tell what is a fatty tissue and which is lymph nodes. So if you can inject, this is a picture, this is from partial nephrectomy, IDG. You can see where the margins are, tumor margins, and then you can stay clear when you're planning your surgery. But this one is here, IDG injected in there, so you can know where the large lymph nodes are, and then you can take the lymph nodes out without taking fat or other tissues, which is not needed. So it just, you inject it and you can see those things in there. So different, and these pictures, they can be superimposed on your screen. And then we talked about you can do remote surgery. A time will come in Pakistan, you have a lot of robots, and one day we start manufacturing our own systems, and then remotely AI can help, where the surgeon can be in the center at PTLI helping surgeons, where it's just a simple thing, it's like flying a drone. You can control the drone from your console and it goes wherever you want it to go. And if you have got a fast internet connection, you can direct your console movements into a remote place, facilitate the surgeons over there. Yeah, so that's the tele surgery, which is the next step. The AI helps with this, and it can be done in another place. So again, this question, and one of the colleagues, top gynecologists, worries about is that robots are taking over from the surgeons. That's not the case. Rather than replace urologists, AI will mainly be used to inform, enhance, and complement their practice. So we are safe. Not in our working life, robots are going to take over from us. Any questions? Please do.
think we've had a bit of a discussion, on artificial intelligence. Any views on it now?
Maybe I can make.
Oh, yeah, sure, please.
Well, as they say, the team is only as strong as its members or the components or machines, and be as strong as its components. So if the humans are going to make the computer and the machines and everything put together, the output may not be as strong or even better than those who are making it. So humans will continue to have the input rather than the threat that the machines or the artificial intelligence will take over totally. Thank you.
Chief Professor Afzal, any response to this?
Sorry, I'm having difficulty, Nusrat Saab, can you repeat the question? There's some echo in the room. Couldn't hear very well.
Well, my comment was regarding the taking over by the computers and the machines and the robots, the total work from the humans. So I don't think this is likely to happen in our lifetimes, at least.
Correct. I totally agree. I think, let's give you an example, because I data share my, because there is some thought behind this, that there could be some auto operating to be done by the simple chores. But to be very honest, let me give you an example. I operated on identical twins, and they both had prostate cancer, strong family history. So I was thinking that I recorded one brother, and a few years later, I had to operate on his other brother, conjoined twin. And I was thinking, they look very similar. I said, their anatomy inside may be very similar. But to my surprise, even those identical twins have their prostatic arteries in a different position. So that made me realize that Allah subhanahu wa ta'ala has made, like this is an ayah in Quran as well, that you all are different. So we are not like cars where robots can just paint the car exactly. They are in the same position, everything, their bumpers and doors and knobs. No. And even a conjoined twins are different. So in order to robots to learn every bit of the surgical or arterial anatomy, they would be they need thousands and thousands of data fed into there so they can sense any eventual anatomical anomaly to deal with it. So that is virtually impossible, because I've got an interest in it. And I don't think so in our lifetime that much data would be available to feed back to the robots so that they learn, and any eventual anomaly possible in humans. So yes, I agree, not in our lifetime.
Okay, thank you. We have another question, please.
Hi, it's a comment. Thank you very much for your talk. I think usually talks on AI are sci-fi talks and looking deep into the future. I am a believer in AI, and I think there is a problem that I do work with lots of data scientists, because my brother is leading one of the IT companies, and we do have a discussion, quite deep discussion about it. There is a disconnect between those people who develop AI, deep learning techniques, and clinicians, because they don't know what we are looking for and what we expect. And then, but we work collaboratively, hopefully we'll keep on pushing the boundaries, and one day we will achieve what we are talking about. Looking into future is impossible. I think everybody can get it wrong. But I think we should be hopeful and working in that direction, that we should achieve that goal one day. I've seen things change in my lifetime, from working, from not even having a landline at my home, with all my life controlled by my telephone right now, within a 20-year period. Thank you.
I'll add this comment. So we're all very unique. We all have our unique fingerprints. There's a 1 in a billion chance that somebody has the same fingerprint. So no two people are identical. Even identical twins are not identical, as you just heard from our esteemed speaker. So it will be difficult to standardize. And human brain has 86 billion neurons. So there are 86 billion synaptic points when you're making a decision or anticipating a problem during surgery. I don't think we have enough data to input the computer for deep learning that they can the computer can anticipate a difficulty or know what will be the next step is. If you know of Tesla and the SpaceX programs, space travel has now become possible because of AI. The AI, it takes the rocket off the ground and puts into the space and then brings it back. And same is when the capsule goes to the space station, is docked by the AI, not by humans, because humans make mistakes, AI does not make mistakes. So there are certain processes that can be automated and led by the AI, but I think we are at least 25 years behind, but it will come eventually.
Thank you very much for your comment, and thank you very much, Professor Naveed Afzal. It was very informative, and I know you personally, you always speak on, and you're a big fan and a big promoter, and you have a lot of information on AI, in the robotics and otherwise. So thank you very much for your time and your talk, and it was really informative. Really appreciate it, and thank you very much. Thank you for the questions. So I think yeah. So basically with this, we're going to move on to our next talk, which is by Professor Faiz Mumtaz, who is an expert on the whole urology, but mainly the upper tracts and on the uro-oncology, and especially in the robotics. In the urology, we do divide upper tracts and the lower tracts. So the anatomy and the working of the robotic is slightly different in the pelvis and on the upper tracts. So, Professor Faiz Mumtaz, can you hear me, please?
Yeah, I can hear you. If you could kindly allow me to share my screens. Thank you.
Yeah, sure. Please go ahead, over to yourself.
Okay, I'm trying to share my screen. That's fine. Right. Can you see me as well? Can you hear me? Hello?
Yes, we can. We can.
We can hear you.
And you can see my slides.
Yeah.
But can you see me on the video as well?
Yes.
Okay. Many thanks. Yeah, and firstly, congratulations to PKLI for organizing such a masterclass, which was absolutely thoroughly enjoyed it. I was able to participate at the meeting yesterday and heard some excellent lectures, and this morning as well. So overall, I think robotics has been launched in Pakistan, and we've heard from Professor Shamim and others. Clearly, it is here to stay. What has really happened, surgical technology and innovation has completely revolutionized how we practice surgery. I mean, if you just go back 150 years back, how anesthesia and antisepsis completely modernized surgery, brought open surgery, surgeons could get on and operate on any organ that they felt like after the advent of anesthesia and antisepsis and antibiotics. And so over the last 2-3 decades now, clearly robotics has again revolutionized surgery, in my opinion, and that's down to surgery. Surgical technology and innovation helped greatly by various industrial organizations. Now, as alluded earlier on, this is a team approach. I was a general urologist 20 years back when I became a consultant. And then 10 years ago, we established a specialist center for kidney cancer at the Royal Free, which has now become one of the largest unique kidney cancer centers, certainly in the UK, as a high volume kidney cancer surgical unit. We in the UK have, as Nadeem said earlier on, have led to significant subspecialization such that we are upper tract surgeons or lower tract surgeons. Now, Royal Free Kidney Cancer Center is predominantly for upper tract cancer surgery. And over the last 10 years, we have developed robotics, and that has now the primary mode of technique that we use for upper tract surgical procedures. Clearly, what has driven the change is not just the surgeon. Although we are innovators, we are motivated, we've self-taught, and we progressed robotic surgery, industry, and the government with the public economic health guidelines have allowed us to bring about patient awareness and education, who are the main stakeholders who have accepted robotics as the way forward. And we've heard all the advantages, a testament to what robotic surgery is able to offer over the last 1.5 days. I won't go on to repeat that, but my remit today is to really highlight how robotic surgery is being delivered for upper tract surgery. Where is the evidence? What are the limitations? How we can improve and improvise. We've heard some aspects from Naveed earlier on artificial intelligence, how artificial intelligence is currently being actively used in our center at the Royal Free. So I'll share some of those points, and then at the end highlight how PKLI would probably need to invest in the development of robotic surgery in Pakistan. In the UK now, a large majority of the partial nephrectomies are done robotically. This is the data from 2018-2019, NHS England, which clearly shows that 82% of the partial nephrectomies are done robotically. In fact, in our own center now, we've audited our data, and almost 90 to 95% of surgeries are done robotically in terms of partial nephrectomy. And so we have again started doing nephrectomies robotically over the last 4 or 5 years. A significant shift has happened from laparoscopy to robotics. And currently 80% of all nephrectomies are done robotically as well. But this has also allowed us to expand the extensions. We are now able to do T2, T3 radical nephrectomies. We have started doing level 1, level 2 cable tumor thrombectomies robotically. So it's clearly enhanced the repertoire of minimally invasive surgery, certainly for upper tract surgery. So once robotics has come through, clearly the objectives for partial nephrectomy have not changed. We should be offering partial nephrectomy only when it is desirable and can be done robotically. The primary objective is to preserve the renal function with the premise that oncological control is not compromised. And at the end, of course, we want to minimize complications and reduce the length of stay in the hospital with the ultimate aim that patients are able to return back to their routine activities and be economically viable in the society and in public at large. So currently, as I said, robotic partial nephrectomy is done in a large majority of the cases. What is the level of evidence in relation to morbidity, functional and oncological outcomes? Is there a randomized study, or are we largely looking at meta-analysis and evidence from systematic reviews? This is the first randomized study completed in Netherlands recently to show that robotic-assisted partial nephrectomy was whether it was superior to open partial nephrectomy in reducing the 30-day post-operative complication rate by 10%. So this was a randomized, open-label, multi-center study, and it's the first randomized study, and it included patients with high complex nephrometric score greater than 7, but they excluded solitary kidneys. And so the aim was to randomize about 300 patients to both arms. I won't go into the details, but the conclusion of the study was that the 30-day complication rate was numerically lower with robotic-assisted partial nephrectomy compared to open. And there was significantly lower procedure-related overall complications with robotics. Overall, fewer high-grade events with intermediate and high complexity tumors. Although the operative time was longer, the hospital stay was shorter. So clearly, the advantages we alluded to earlier on with robotics were seen in this randomized study. This study had to be stopped because under recruitment, more patients wanted to go ahead with robotic rather than open. But the trend was towards a better outcome in terms of mobility at 30 days. If we look at a meta-analysis comparing open partial nephrectomy to robotic, again, all the advantages are again seen with robotics. And I won't go into the details. We have similar benefits were seen, but importantly, recurrence rates were low and hospital stay was significantly reduced. If we compare the robotic partial nephrectomy to laparoscopic partial nephrectomy, again, we saw that robotic partial nephrectomy group had larger tumors, high nephrometric scores. We were able to offer partial nephrectomies, decreased risk of conversion, more importantly, decreased risk of positive surgical margins, and a shorter warm ischemia time. And these were the conclusions from the systematic review. Cost is again a big issue. Again, cost has been compared for both robotic, lap, and open. Generally, the variable costs are higher, room supply costs are higher with robotic partial nephrectomy, but can they be overcome by longer hospital stay with open partial nephrectomy? Again, the analysis again showed that if you reduce the length of stay by 2 days and reduce the operative time by 30 to 60 minutes, which is possible and has been achieved currently in our center as well, will it make robotic partial nephrectomy cheaper? We have gone on to use single needle holders for partials. We try to avoid hemostatic agents to make it cost neutral. And these are things that I think in PKLI one may need to look at. How can we reduce the amount of instruments that we use? Because that's what will drive the overall cost in Pakistan rather than the hospital stay. So that's something that with time, you guys will be able to look into it and hopefully reduce the cost. We've highlighted earlier on, should we be centralizing complex robotic procedures or indeed in Pakistan currently, the way it is, it should be robotic surgery should be centralized, and the primary aim would be again to reduce length of stay and will help health economics in Pakistan. Will it allow it to make it cost effective? Again, as I alluded earlier, reduce the number of consumables that you use, and hopefully it may become cost effective. Now, partial nephrectomies, the question is, can all of them be done robotically? Clearly, we currently have lack of haptic feedback, so tumors that are more challenging may be difficult to offer robotic procedures. Vision, again, as alluded earlier, we have to modify our vision to improve our cancer margins. And how have we been able to achieve this? Clearly, the challenges that we see are we need to extend the indications for partial nephrectomy, single kidneys, horseshoe kidneys, patients with impaired renal function. Can we use eyes robotically? Tumors that are endophytic, highly infiltrating tumors, can they be done robotically? And those are the challenges, and how have we overcome them? We at the Royal Free, we have a surgical planning meeting every week prior to our next week's theatre list, where we look at all the preoperative images. And we have now been using over the last 4 or 5 years a 3D surgical roadmap, which I'll share with you. We sometimes use a Firefly, but with almost 100% use robotic ultrasound. And there are things that are in development like overlay navigation images and visual biomarkers, but they're still in development and currently being looked at our center very actively. Normally, when we plan partial nephrectomy, we look at our triple phase CT, look at the tumor and its relationship to the blood supply, and then have a mental image of the number of arteries, the relationship of the tumor to the arteries, the veins, the collecting system, and then take that information to the operating console. But to help us improve this, we have developed a 3D software, which is machine learned AI algorithm, developed 3D models from our current 2D scans. And I'll share this with you. This is a large tumor. You can see the roadmap of the arteries. You can make the tumor transparent. You can see the depth of the tumor, the collecting system, the renal sinus fat. You can make the kidney transparent, turn it around and see the depth of the tumor. And you can take all this to the robotic console as well, which I'll share that with you subsequently. So going prior to theaters, you know the roadmap, the number of arteries, the relationship of the artery to the tumor, the depth of the tumor, the base of the tumor, you can plan your rhinography and see how you're going to be taking the various vessels, avoiding the collecting system. So all that can be planned prior to surgery, which is both good for training as well as planning for surgery. Again, this slide is just simply showing the depth of the tumor, the base of the tumor, and you're planning for surgery. For single kidneys, again, for segmental clamping, you can see the course of the renal arteries, and you can see the roadmap and plan which vessels you're going to segmentally clamp rather than do a complete clamping of the main artery. So the tools for surgical autonomy we have heard earlier on, the three things that we are used routinely are Firefly, robotic ultrasound, and Doppler probe. As I said earlier, we routinely use robotic ultrasound to outline the margins of the tumor. Firefly, the benefits of Firefly are if you have clamped the main artery, you can see whether there's complete ischemia achieved. For segmental clamping, you can again see which they have achieved the necessary ischemia to excise the tumor. And for differential perfusion, it may help you to have a clear margins when excising the tumor. And this is a video of just showing how Firefly has been used to show that we have been able to achieve a surgical margin. So you can see the base of the tumor, all green, showing that we've taken a normal, healthy kidney, which was perfused when given endocytomy. So the next step for a partial nephrectomy is the tumor control. As I said, routinely use ultrasound is not a luxury, and the purpose of the ultrasound is to locate the tumor, particularly when you have toxic fat, small tumor. That's really where ultrasound is beneficial. So you don't need to defat the whole of the kidney. You mark the edge, understand the depth, and plan your direction of resection. And any venous involvement you can recognize by an ultrasound. So we can use all the three modalities, the 3D imaging, as well as the ultrasound. And I'll play this video, which you can see here. There were multiple arteries, about 4 arteries, all were isolated on the 3D image. And we have isolated them. You can put the Tile Pro, the 3D image as well. You can use the robotic ultrasound to mark the tumor, which is being marked looking at the depth of the tumor, as you can see here. And you can recognize it with the 3D image. And once that is marked, then you can go on to do your rhinography. If any doubt, you can revert back to 3D imaging and see the course of the arteries. If you miss any artery, you can go back and identify a missing artery, isolate it, and sloop it so that you can achieve satisfactory vascular control before embarking on a partial nephrectomy. So this is the second artery. Now this is a tumor that has been marked after using the robotic ultrasound and then excised, and that's the final image of the partial nephrectomy achieved using sliding clip rhinography technique. I mentioned to you about the use of ultrasound. This is another short video showing, one would think that this is the edge of the tumor, but as you go on to put the ultrasound, you'll see the tumor is extending further inside, and then you can use that to help delineate the extent of the tumor and mark it appropriately, and then excise the tumor. Rhinography, prior to doing a rhinography, have a clamp timeout in which you make sure that your sutures are well prepared, trocars, needle drivers, enough insufflation, mannitol, bulldogs, all the instruments that you need are available before embarking on a rhinography. This is a short video of a complex partial nephrectomy highlight tumor that was sitting on the main renal vein. And as you can see, the dexterity and the ability of the robot with this endo-wrist movement, allowing all the vessels to be identified and individually secured prior to complete excision of the tumor. So all these separate vessels are identified, and He can place hemolocks. Hemolocks are safe to place even in the internal urinary bed, as long as they're placed appropriately. And once the tumor is then excised, then the internal urinary, again, the benefits of the endo-wrist movement allows you to very precisely close the edges of the veins that were opened rather than laparoscopically, which again would be quite challenging. And again, this is the final appearance of the partial nephrectomy. So robot, I think, has this definite role in partial nephrectomy. What about nephroureterectomy, which is another challenging procedure? And clearly in our institution now, compared to what we were in 2017 and now in 2021, I would say to you in 2022, 90% of all the nephroureterectomies are done robotically. And the benefit with the excise, again, single docking, you don't need to undock and redock for the pelvic part of the procedure. It allows you to have a bladder cuff excision, a watertight repair, and an nephrectomy, when necessary, with lymphadenectomy, all completed in one single docking setup. And so in our center now, almost 90 to 95% of nephroureterectomies are done robotically. This has allowed us to look at the safety and feasibility of giving early single-dose mitomycin. And this is a study from our center in which we looked at the first 69, 70 patients when we were able to close the bladder cuff with the intraoperative bladder leak test showing no leaking. We were able to give mitomycin on the second day or the third day post-operative. And so we think that mitomycin can be very safely given post-nephroureterectomy. Will it reduce the long-term impact on recurrence-free, which is the main determining factor currently and being looked at to see robotics or laparoscopic technique, will it reduce the risk of bladder recurrence? And I hope with better watertight closure and early mitomycin installation, we might be able to reduce the risk of recurrence. We're going to audit our data, and I'm sure in the next 5 years, we'll be able to present that. So this is a meta-analysis, again, looking at robotic versus other nephroureterectomy techniques. There were 80 studies, large numbers of open nephroureterectomies, similarly large number of nephroureterectomies laparoscopically, and large numbers from robotics. And the outcomes were not surprising. Reduced blood loss, complications, and length of stay was significantly lower. But there was no correlation between the surgical technique and recurrence-free and cancer specific survival for any of the techniques. But we feel the robotic nephroureterectomy is still evolving. Again, this is a study looking at a tetrafactor, just like the trifecta for partial nephrectomies. They looked at a composite tetrafactor, looking at whether you are able to excise the bladder cuff, able to do lymphadenectomy, number of complications, and negative surgical margins, comparing robotics with laparoscopic nephroureterectomies from 2015 to 2019 in 17 centers. And the conclusion was that, yes, robotic nephroureterectomy, you're more likely to have a bladder cuff excision, significant again, reduced post-operative complications, significant, and reduced length of stay, again, significant. And the meta-analysis showed that you're more likely to achieve tetrafactor with robotics than with laparoscopic. So again, testifying that, yes, robotic nephroureterectomy has a role and continues to evolve. And in terms of their intravesical recurrence rates, they were not any different between the three techniques, although the trend was slightly lower for robotics. Time to progression was not different. Progression-free survival and overall survival were also similarly not different. This is the data from BOWS, recently BOWS national audit. How do we manage the distal end of the ureter, which is the most controversial part of nephroureterectomies currently and being looked at. As you see, they had about 1,500 TCT cases from 132 surgical sites, 285 surgeons, showing that still subspecialization has not taken place in the UK. That just shows there are about on average, 3 to 4 cases of nephroureterectomies per surgeon on average, which is not a desirable feature, although there are centers that are just doing 1 or 2, and that needs to be stopped. But what the audit did show that there was no significant difference between average blood loss, length of stay currently, but between all the three techniques. Clearly, robotics has a role to play because it's safer in terms of reducing the Kelvin Klein greater than 2 complications compared to open surgery. And as you can see with open surgery, there were higher number of complications compared to robotics, but that remains to be seen. The overall outcome from this audit was that the bladder recurrence rates were similar for both laparoscopic and robotic, and that needs to be looked at. Local recurrence rates were significantly lower for robotics, 0.9% compared to 2.8%, but again, that needs to be looked further. So this management of the distal ureters is still under review, and I think we haven't really identified the preferred technique because distal ureteric tumors have really poor prognosis, and I think a lot of work needs to be still done to identify what is the best possible technique to excise the distal ureter. And we, as a large specialist kidney cancer center doing the highest volume nephrectomies, hopefully I think we should seriously look into see how we can reduce this risk of bladder recurrence following robotic nephrectomies. Pyeloplasty, again, yes, wherever robot is available, pyeloplasty is being done robotically. Again, because of this precise suturing, shorter learning curve, lends itself to be an attractive technique. Whether the long-term results in terms of clinically significant are unclear. This is a large meta-analysis looking at about 4,000 patients. Yes, the hospital stay is shorter. Operative time is much shorter because extensive suturing done by robotic, which is much better compared to the laparoscopic route. But the question still remains, is this statistical advantage, does it relate to clinically better outcomes? And that still needs to be seen. I think clearly in high volume centers, a randomized study is probably worth doing to put a bit to rest. But I think overall the feeling is robotic pyeloplasty is a superior operation compared to laparoscopic. Nephrectomies, as I said to you, in our center now, 70 to 80% of nephrectomies are done robotically, and we have increased the repertoire by increasing into T3 tumors and tumors invading the renal vein and level 1, level 2 IVC. And the meta-analysis looking at between the outcomes does not support any significant difference, but the trend is towards reduced operative time, length of stay is reduced, and conversion rates, although not statistically significant, but the trend is there. And I think, again, a randomized study is worthwhile doing. Other robotic techniques that can be used are retroperitoneal lymphadenectomy, uterolysis, implantations. So robotic surgery is here to stay. For PKL and other upcoming institutions, I think it's best to centralize your care, surgical care, increase the repertoire of MIS as you go on with the hope to improve cancer outcomes, develop training programs, and maintain your skills in innovation and research by auditing and doing prospective studies. So on that note, I thank PKLI for giving the opportunity to present this. And I say finally that make your robot efficient and effective to do the right things. Thank you.
Thank you very much, Professor Fez. It was very elaborate, and you have covered all the aspects of the upper tracts. We really appreciate your talk. It was very informative, and we will keep you on board. Soon we get the robot on the ground. And as you know, we've already spoken to yourself that we'll keep you involved in the robotic program. And thank you very much. Without wasting our time, as a host, I do appreciate patience of our chief guest, and I do appreciate. I mean, it's a realistic comment. I do appreciate your patience. It is very exhaustive. It's from 9 to 5, so it's very tiring as well. So, but the last two talks for 10 minutes each, we'll try to make it as short as possible. But the second last talk was about role of pelvic surgery. My initial understanding when I started the robotics, that the robot was made for the pelvic surgery. But then when I realized that there is, the hepatobiliary and the anatomy of hepatobiliary, I realized no, there is more deep inside and there's more corners around in which we need to get in through the robot. And then came, the other specialties, upper GI, esophagectomies. So, I mean, it has no bounds, it has no limits. But I have requested one of my other colleagues to show us the role of robot in the pelvic surgery. And then, the last topic is very interesting because I requested, I was trying to find any colleague who has transformed from Da Vinci to Orseus, from intuitive to CMR. So basically we have that guy who has this transformation. So I was very keen to, and I was trying to find someone who has transformed and he can share his experience. So I think the last talk is going to be the most interesting. So I really appreciate your patience. And we have Dr. Sarfaraz Ahmed. Over to you, Sarfaraz. Can you hear me?
Yes, I can hear you.
Mudassir, I don't know.
Can you see my slides?
Yes, Sarfaraz, we can see your slides now.
Okay, thank you very much, Dr. Nadeem, for this opportunity, and congratulations again for starting this masterclass. I heard that you have given me 10 minutes, so I'll try to be as fast as possible. I have to cover robotic-assisted pelvic urological surgery. This is my disclosure. I'm intuitive Da Vinci trained urological surgeon. If we talk about what urological procedure we can do in pelvis, there is a list is long, but most commonly procedure are prostatectomy and cystectomy. And the focus of my talk will be on these one, and a special focus will be on the technical aspect. I will show some video, and for the sake of time, I'll try to run this video as fast as possible. So when we want to do a surgery, especially for cancer in pelvis, we want to do a surgery which is safe. Cancer cure is priority, and we want to have a good functional outcome. And robot has provided these advantages for cancer surgery, whether it's prostate or bladder, we can achieve all these three goals. This is our standard position for pelvic surgery when talking about prostate or bladder. This is with SI. With XI, there is some modification in this position as well. The port placement is, this is my standard port placement for cystectomy patient. I use 6 ports, 3 are robotic ports, and 3 other ports. 1 is camera and 2 assistant port on the left side of the patient. So this helped me to do intracorporeal urinary diversion. For the prostate patient, I move this port, assistant port, to the right side, and these robotic port will go on the left side. And for the prostate, we use 1 5mm port rather than using 2 12mm ports. So if we talk about the robotic radical prostatectomy, there has been evolution for over a year now. The first time transperineal radical prostatectomy was performed more than 100 years ago, and it took nearly 40 years to do the retropubic prostatectomy, and then another 40 years to develop nerve-sparing prostatectomy. Then the 1992 came, and we have a laparoscopic radical prostatectomy, and then a robotic prostatectomy. And the things have not stopped since then. There have been multiple evolution in the technique. We have ridge sparing, single port, and there is now more advancement expected with the use of artificial intelligence microrobots. And these techniques will keep evolving over a period of time. So in today's discussion, I will just focus on retropubic robotic assisted radical prostatectomy, which is done by steps. We have 8 standard steps, which start with the lateral dissection, bladder dropping, bladder neck dissection, identification of seminal vesicle, then posterior mobilization, nerve sparing and urethrovesical mobilization, and retrieval of specimen, and a lymph node dissection in a selected patient. I normally like to do the posterior dissection first, which provide a better understanding of anatomy and prevent any damage to the rectum. I will show in the next video how it is done. I hope you can see the video because there is some lag in the videos. Can you see Dr. Nadeem? So this is shown that we divide the peritoneum and identify the seminal vesicle by initially identifying the vas deferens. Then continue dissection to identify the seminal vesicle. The advantage of this technique is that when we start the procedure, bladder and prostate are still attached to the anterior abdominal wall, and we have the anatomical advantage that we can do the safe dissection in this area. And the same procedure is repeated on the other side. And if it is feasible, we can divide the non-villus fascia and lift the prostate from the rectum to develop the space a bit further. Following development of the space, the next is the lateral dissection, which involved giving incision on the anterior abdominal wall lateral to the medial umbilical ligament. And this dissection is now progressed more to the pelvis. We identify the lateral pelvic wall and then define our limits by identifying the prostate and a bladder. At this stage, we can control the DVC to have a better hemostasis, which can be used with the sutures. Sometimes we use the stapler, but the suture technique is better, and we can do a better hemostasis, and soon applying after the DVC, the hemostasis is much better. So another important aspect, like when we talk about the prostate surgery, we not only want to cure the cancer, but also want to improve the function and preserve the function. Majority of the continence in male patient is from the external urethral sphincter, but also bladder neck has a lysosphincter, which is important in continence. And it has shown like if we preserve the bladder neck, the continence is better. So whenever it's feasible, we like to preserve the bladder neck. However, in certain cases, when there is a previous TURP or there's a large median lobe or tumor is located close to base of the prostate, the preservation is not achievable. In this situation, cancer cure take priority rather than preserving bladder neck. The video show how the bladder neck dissection is done. So we identify the prostate, then a junction between prostate and a bladder, which is dissected with the diathermy. And at this stage, we can ask our assistant to use put a traction on the catheter to identify the demarcation between bladder neck and the prostate. And when we keep deepening this dissection, we should be able to see the catheter. And the next step is to pull the catheter and ask the assistant to apply traction on the outside as well. And this is very important because when we have a good traction, this will allow us to further progress in our dissection laterally and also posteriorly to identify bladder neck. So the rest of stuff is that try to avoid working in a hole. Whenever there's a difficulty, we need to make dissection a bit more lateral to allow to reach to the posterior lip of the bladder neck. So once we have identified the posterior lip of bladder neck, at this stage is a kind of vertical down to go directly to the seminal vesicle, which we have already mobilized. To have more traction, we can drop the bladder catheter and hold prostate to identify our seminal vesicle, which is now visible at this level. So following identification of seminal vesicle, this is the development of pre-rectal space. After opening the non-villus fascia, mostly dissection is done bluntly so that we can not have any damage to the rectum, and slowly we can move rectum away from the prostate. And this is an important step to have a posterior mobilization of rectum. The nerve sparing is an important aspect of prostate cancer surgery, especially in a younger patient with a normal erectile function. There have been various techniques and described for the nerve sparing, but the bottom line is that if we see where is the nerves run posterolateral to the prostate and seminal vesicle. They are in the fascia between the prostatic fascia and endopelvic fascia. This is a plane where nerves are located, and we can do intrafascial when the dissection is done very close to prostate, preserving full nerves. Interfacial is when we are doing dissection in between these two layers, and extrafacial, which is basically non-nerve sparing, technique, which is done outside in cases when the tumor is advanced. There are other terminologies used as well, full, partial, minimal, corresponding to these dissection planes as well. So if we look at intraoperative, where these nerves are located, so once we have lifted the seminal vesicle as shown in this picture, the nerves are located in this triangular area. And when we have to mobilize the neurovascular bundle, this is the area of our dissection where we need to proceed from base of the prostate and progress this dissection on toward the apex. This small video will demonstrate the technique of intrafascial nerve sparing on the right side of the patient. So this is neurovascular bundle is being mobilized from the prostate. We are staying very close to prostate. At this stage, it is important to use minimum diathermy on the neurovascular bundle. If we have to use, we can use pinpoint diathermy. And usually this is done with the blunt dissection, avoiding much traction on the neurovascular bundle. And when we identify the pedicle, these pedicles are tied at the same time when we're mobilizing the neurovascular bundle. Once pedicles are tied, the traction on the seminal vesicle will help to progress further on the mobilization of the neurovascular bundle. The clips are being used. This area is this part usually a bit more bloody, but suction is there all the time, and the assistant can use suction irrigation to keep vision clear, which is very important to achieve a good nerve sparing. So by continue with this dissection, we can reach to the posterior of the rectum, where we have already done our dissection. And by doing this one, we have released the neurovascular bundle completely, which will be helped to maintain erectile function in such patient. The apical dissection is critical for a complete cancer cure, especially if the cancer is located near the apex. And also dissection need to be precise to make sure we have enough length of the urethra, because this will provide a return to continence quicker. What we normally recommend, like the dissection in this area should be done under less bleeding or minimal bleeding. We can use our assistant to use suction irrigation, and our dissection cuts are really small to avoid any bigger cut or damage. And slowly we can push down the apex toward prostate and identify the urethra. But the key feature at this stage is that not to have a bigger cut, small cuts, and whatever we are cutting should be under vision, and try to avoid using too much diathermy. It is important to remember that all the apexes are not the same. The preoperative analysis of the MRI scan and intraoperative careful dissection will allow us to have a precise dissection at this level, and also preservation of a good urethral length, which will be helpful in continence. So by doing this one slow and steady steps, we are not only able to move apex away, but also achieve a good length in the prostate urethra. The final step is that once the specimen is removed, we need to join urethra with the bladder. There are many techniques, many different methods are available, but the key principle is that the anastomosis should be watertight, mucosa to mucosa, and it should be tension-free. We can use a single suture technique, which is shown in the top video, or we can use a double needle technique, which is really advantageous. And I like to do this technique for most of my cases. You can use both hands quickly, and this is the advantage of robotics, that you can manipulate in difficult areas, and the both needles can be used. The important thing is that whenever you do whatever technique you're using, it should be directly into vision, full thickness, especially from the bladder side, and also it should be watertight and tension-free. So in the next few minutes, I'll just show a few videos of robotic-assisted radical cystectomy. We have, when the robotic surgery was started in urology, there was a very rapidly intake of prostate by many colleagues, but this was not the case in cystectomy. There was resistant in accepting robotic cystectomy. There were many reasons, maybe a complex operation, there was not enough data available. However, in the last 15 years, there have been an increased adoption of robotic assisted cystectomy across America and Europe. And you can see there is nearly double the number during the last few years of robotic cystectomy adoption. Additionally, there is also more procedure are done by intracorporeal approach rather than extracorporeal, which was the case at the start. So most of the procedure now are done by intracorporeal. So the steps in male is, if we divide, there is 8 main steps of cystectomy, then there's a lymph node, and then the urinary diversion. Next 3 minutes, I'll just show you one video, which is just highlighting these steps. When we start the cystectomy, we start procedure on the right side to identify the ureter. And this has advantages because the sigmoid colon is still attached to the left wall, and we have plenty of space. Identify the ureter, it is slooped. And after slooping, we'll carry on the dissection distally to reach to the bladder and then divide ureter between clips. After doing this one, the same procedure is repeated on the left side. And after clipping both ureter, the next step is to development of retrovesical space. The principle are same as we have done for the prostate. We'll join the peritoneum from the midline with the lateral dissection, which was done for the ureteric dissection. This dissection will allow us again to develop a space while the bladder and prostate are still attached anteriorly. After developing the retrovesical space, the next is to isolation of the pedicles, which we perform by mobilizing the pedicles from the lateral pelvic wall. And slowly these pedicles are made free, and under direct vision, we apply hemolock clips and divide. So this procedure is now carried forward to the prostatic pedicle until we fully control the pedicles on both sides. And once we know that pedicles has been both released on the both sides, the next step is dropping the bladder from the anterior wall. Now we have mobilized bladder posteriorly, and also pedicles are controlled. So this is the time when we can drop the bladder from anteriorly by giving incision on the peritoneum lateral to medial umbilical ligament, then dividing urachus and reaching to the pre-prostatic area. And after reaching there, we can control DVC by suture, and following suture application of the DVC, the urethra is divided. In this case, we were doing ileal conduit, so we don't need to worry about the urethral length. If we are doing a neobladder, then the urethral length need to be preserved to allow anastomosis. We always put a clip before dividing urethra to prevent any spillage. And once the urethra is divided, the specimen is placed in a bag. In interest of time, I'm just skipping a lymph node, but we will just show you the ileal conduit formation in this 1 minute video. That once we have our ureters divided, specimen in a bag, we develop a window in the sigmoid mesentery to bring ureter from the left side to the right. This will allow us to do our anastomosis. Then we isolate our ileal conduit using a stapler. About 15 to 20 centimeter loop is separated. And after isolation of the ileal conduit, the bowel continuity is restored by using a stapler and side-to-side anastomosis. If it's normally I used 2 staplers until we are happy that 1 stapler is enough. This will allow us to have a quite wide lumen, and end is closed by applying another stapler. Subsequently, once we know that bowel continuity restored, the ureter anastomosis is done as we do for our open. In this video, we're just showing using the Wallace technique. We make a plate posteriorly first, and then later on with the ureter are now joined with the ileum. Ureteric stent are placed, which are brought outside from the other end of the conduit. Further anastomosis is completed. And the conduit distal end is now brought to the outside on a pre-mark area to make a stoma. So there are few challenges, especially when we see the patient age. We have a younger population for the prostate and an elderly patient for the cystectomy. So we need to consider these factors. Disease factor need to be also considered, and also human factor, which has been highlighted in previous talk. The teamwork is vital, especially when we're doing very complex procedure. This kind of patient we can get with the obese patient with previous surgery. This is one of my patients which have previously sigmoid colectomy, then open cabbage. Intraoperatively, we did a intracorporeal conduit and cystectomy, which went well, but we encountered some adhesion, which was dealt with. And in certain cases, robotic may not be feasible. This was a patient with a very big bladder with full of tumor, and we have no space to mobilize, and we convert this patient to open quite early. The bigger patient tumor have worry about positive surgical margin. Sometimes if you have to do robotic surgery, cystectomy with uretrectomy is required simultaneously. This can also be done. In this patient, we did robotic cystectomy with the intracorporeal conduit, then use retropubic and peripubic approach, open technique to remove the urethra. Transperineal approach can be done as well. The main thing is that when doing the pelvic surgery, planning is important. Either it's a prostate or bladder cancer. Planning and vigorous analysis of the images, pathology result, and the team planning is important. Learning curve is always issue in the robotic, but if we can get over our learning curve sooner is better. The key is that whenever we're doing the procedure, try to repeat same procedure each time, which helps surgeon to improve and also help team to improve. Thank you very much.
Thank you very much, sir, Faraz, and my sincere apologies for cutting you short from 20 minutes to 10 minutes. But my idea was that if you can cut the surgical time from 6 hours to 3 hours, you can definitely cut your talk from 20 minutes to 10 minutes. So my apologies, but I was pretty sure that you could do that. And thank you very much for doing that. Any questions? Any comments? I think we'll have to move on now. So thank you very much, Sir Faraz. I really appreciate. And if, hopefully, as I always say, when we will have the robot down on the ground at the PKLI, we will definitely invite you. So thank you very much again. Now, finally, the last but not the least, our most important speaker, Mudassar Hussain, patiently waiting for his turn. And I purposely invited him for the reason that, for me, I was very curious, especially to hear from the person. Yes, I have been doing Da Vinci, but I haven't used the CMR. But the thing is that, I wanted to find, someone who has used both the systems and who can highlight the difference and, and to give us a practical feel about them. So thank you very much, Mudassar, for sparing time for us. Over to yourself. Thank you.
Assalamualaikum, everyone. Hopefully you can hear me and see my slides. If someone could just let me know, please. But thank you very much for the invite, and I'll try and get through this talk, inshallah, in good time for some questions at the end. So just a few conflicts of interest to start with. I do actually use both robotic systems, so that's Da Vinci Xi and also the CMR Versius. I'm a preceptor for CMR and also in the process of becoming a proctor for Intuitive. So hopefully I will provide an unbiased view, but maybe you might tell me otherwise by the end of the talk. So my journey with Pakistan robotics actually started over 5 years ago when I was invited to go down to Karachi to help them with some retroperitoneal robotic surgery. So I'm very interested in Pakistani robotics, and inshallah, I will get the opportunity to come to you guys and help with your robotic program if necessary. But today I'll just tell you a bit about myself and why I feel that I'm in a good position to talk to you about these two systems. So I CCT, which has completed my certification for training in October 2015, and then I did a robotic fellowship at my institute in Surrey in Frimley Park Hospital. And now there are 3 robotic surgeons there, and we perform just under 200 robotic partial nephrectomies a year in our one center between the 3 of us, and just under 95% of them are retroperitoneal. So that was my background, and that still is the current play. In terms of the CMR experience, I was involved in the preclinical trials. So that was in around 2019, and I became the first UK CMR urology surgeon in 2020. And actually, because we had both systems, we were actually the first in the world to have both systems for urology. And luckily, because that was the case, I was able to be, perform procedures for the first time in Europe as listed there. Like Professor Mumtaz, I'm also an upper tract surgeon. So apologies for you guys who are pelvic surgeons, but most of my talk is related to upper tract surgery, predominantly nephrectomy and partial nephrectomy. So I'm just going to talk a bit about the intuitive Da Vinci to start with. There are 3 main components to the Da Vinci, as you guys might know. You have the patient cart, the console, and the vision cart, and this is already different to the CMR, which I'll show you. There's no vision cart for the CMR. You can integrate the vision for the CMR into your current vision setup and your stack in theatre, whereas with the Da Vinci, you do need to purchase their vision cart. The patient cart is quite a big structure. It's just over 2 meters high, and it weighs over 800 kilos. It's a significant structure, and you do need a big theatre to be able to house this, and you need strong enough floors to be able to take the weight to make it stable. But it's a single patient cart, which is different to the Versius, which I'll show you shortly. The surgeon console, you need to be seated because there are pedals which you need to use for clutching the camera and also for electrocautery. And it's very ergonomic in terms of you can move the armrest and the headrest to make it more comfortable for you. The experience as a surgeon is completely immersive. You're using this binocular 3D vision. There are no distractions at all. Handpiece. Now, this is one of my favorite parts of the intuitive Da Vinci Xi and previous models. It's got a pincer grip, and there aren't many buttons. There's one lever, which some surgeons like myself use for clutching. Other people actually use a foot pedal for clutching, but this is the handpiece, and I'll show you the differences with CMR shortly. This is an overall picture of the CMR Versius. So you've got the surgeon console on the left, and then you've got the patient carts, plural, on the right, and each individual cart holds one instrument. So you'll have an endoscopic arm, and then you'll have either 2 or 3 additional robotic arms. There is one commercial video I have in this talk. I won't play it all. Inshallah, it will work. Sorry, it's being a little bit slow, which just shows the open console. So there's the surgeon who has clear communication pathway with the surgical team if required, and also with her anesthetic colleague if required. And you can also access the patient at all times. There's not a big patient cart which is in the way. These small bedside units are actually quite small, and I'll show you a bit more detail later. So this is kind of an overall setup of a theatre, and you can see the floor space it takes up is a bit less compared to the Da Vinci setup. Each bedside unit is 38 centimeters by 38 centimeters and weighs about 100 kilos. So it is actually quite portable. And this is one of the CMR's favorite pictures showing how portable the units are. Obviously, this is just for commercial reasons, but these units can be moved quite easily between theatres or even between hospitals, and that is quite difficult with the large Da Vinci robot currently. Although not impossible, I think it's easier, and this second robot is a bit more portable. The surgeon cart or the surgeon console is also quite different it has extremes in height adjustment, which actually mean you can do the procedure standing, which some people prefer. There are no foot pedals, which is why you can stand. However, the handpiece is very, very different. And this is one of the main differences to the Da Vinci robot. This handpiece, people liken it more to a games or video games controller, like a PlayStation or an Xbox. There's a few buttons and a joystick in left hand and right hand. The joystick does the endoscope in and out, left, right, up and down. The larger button does the clutching, the instruments and the camera. And then you have a smaller button to activate either the bipolar or the monopolar. So this is very, very different. There's no pincer grip here. You have an index finger, which moves in and out to activate your grip. Instrument portfolio of the CMR Versius is currently not as vast as the Da Vinci setup, but obviously Da Vinci has been around for 20 odd years, and this has only really been used for a few years. So currently there are cold scissors, monopolar scissors, needle holders, graspers, a hook, and a Maryland bipolar. So that's the only instruments that are currently available. However, other instruments are in development, like bipolar energy, advanced energy, stapling devices, etc. What CMR Versius have been very good at is their ecosystem. And you might ask, well, what does that mean? But it's a digital interface between the patient and the surgeon, and actually between surgeons in the hospitals, in the countries, and even around the world. So as soon as the case is finished, the case gets uploaded to an app on your phone, and you can get telemetry data, which you can compare your operative procedures and timings to other surgeons in your hospital or even around the world. And the data accumulation is really, really good. The other thing that's fantastic with CMR is the way they set up surgeons. So you start off with an e-learning module, then you get the Versius trainer, and actually they've got a virtual reality setup, which you can actually take at home, which is fantastic. Instead of staying after work, evenings or weekends to use the simulator, you can actually use a virtual reality headset at home. You then go to a cadaveric lab to do 2 or 3 days to do your procedure, have a dry run. And then the first few cases are performed with a preceptor. So someone like myself or someone who has some experience with the Versius robot, who's with you to help you with the technical side of things. And if you need ongoing support, this can be through telementoring. So I think the training and the clinical governance involved in starting new surgeons is amazing. This is from their website as well. It tells you reasons why Versius might be good. But for me, I've circled the main reason. This is a long-term two-way partnership. It's not just a sales process. A little bit of my experience with Da Vinci is they give you the robot and then you're almost left on your own. The CMR team are fantastic. They're very approachable. You can text or call the chief medical officer and he'll get back to you the same day. If you've got some feedback, you need to let them know because they are still in development. This is still a new robot. If you have any ideas, any suggestions, you tell the team, and honestly, within a few months, you may actually notice that your suggestion has been made into reality. And this is a journey that is not yet completed. These are some of the cases that go on. This is a recent slide. So urology is only 20% now, but you can see all the other specialties that are in use. And actually, quite recently in Guy's Hospital in London, they performed the first transoral robotic surgery. So, the 2% of other cases, they will expand. And like we've talked about, there's lots of specialties that robotics can be used in. These are the cases that I've performed personally with Versius. So initially we started off transperitoneally due to a rule that you had to operate 5 centimeters away from the port. Now that software has been updated and you can actually operate within 2 centimeters of the port. And therefore now we can perform a retroperitoneal surgery, which is the mainstay of my practice. I've just got a short video again, inshallah this works. This is a transperitoneal, a lower pole, partial nephrectomy. This is the rhinorrhaphy. So the excision's been done with what appears to be a macroscopic negative margin, and this is just showing you some of the dexterity available with the CMR robot. In this instance, I've used 2 needle holders, but to be honest, to save costs, the left hand could be a Grasper or a Maryland's. This was in the early stages, I think, when they suggested to use 1 in each hand. And you can see the dexterity it allows you. It's actually very similar, if not the same, as the Da Vinci robot. So you can do some quite complex renorraphies and reconstruction with the CMR robot. So I've just got 2 robotic arms here and 1 endoscope, and then 1 assistant port here. So I have 4 ports total for my robotic cases, and this is CMR. So I don't really need to show you all of this video, but it just gives you an idea as to the dexterity and the instruments that are available. Right, so CMR, it was suggested in 2014, but the first case wasn't performed until 2019. It's very portable. You can sit, you can stand. There's an open console which allows for communication with the rest of the theatre team. The handpiece is very different. It's very, very different, but it's easy to get used to. The other thing I haven't mentioned actually is the instruments. These instruments are all 5mm instruments, and the endoscope is 10. So the pros and cons of that is the ports are smaller for the 5mm instruments, obviously. However, you cannot port jump like you can do with the Da Vinci Xi, because everything on the Xi is 8mm. You can move the camera to an instrument arm or vice versa. You cannot do this because the endoscope is 10mm, instruments are 5mm. It is compatible with existing theatre equipment. You do not need the vision cart like you do with Intuitive, and the cost, every hospital is probably getting a different deal, but overall the cost is less than the Da Vinci. Some of the things that we need to think about when transferring to the Versius is the port and the bedside unit position are very dependent on the patient and the case. For example, with Da Vinci, there tends to be one setup, especially with the Xi. You could pretty much put the ports transperitoneally in one line for upper tract surgery, and for retroperitoneal surgery, a similar one line across the side. With the Versius, I'm afraid, for transperitoneal surgery, you do more of a laparoscopic setup, and there are some surgeons who actually use it as a hybrid procedure. So they do dropping the bowel laparoscopically, maybe use the robot for the hilum, or maybe for the excision renorraphy, and then back to laparoscopy to mobilize the kidney and put it back in the bag, etc. So lots of places do this as a hybrid procedure. One of the differences with using a Da Vinci and the CMR is you have to change your mindset on the bedside units. With Da Vinci, you dock the robot, you start the procedure, you finish the procedure, and you undock. With CMR, you have to be willing, ready, and able to move the bedside units during the procedure. And you may ask why, and the reason could be, especially with upper tract surgery, is some positions of the bedside unit allow you to access the lower pole of the kidney perfectly. But then when you try and go to the upper pole or to do your adrenal sparing or whatever you want to do, sometimes the reach is not there, and you have to undock and you have to reposition the bedside unit and redock for the upper pole. So initially, that's a big frustration for Da Vinci users because we're not used to these interruptions in the surgery. But once you accept that and you adjust your mindset that you will have to move the bedside units occasionally, and moving them takes 30 to 45 seconds. It doesn't take very long at all. Once you get used to that, you can really get the best use out of it. Like I mentioned, I'm afraid there's only 6 or 7 instruments at the moment, but there are, developments of advanced bipolar. They're talking about ultrasound, Firefly. All of these things are coming. There's currently no 3D reconstruction software. The Da Vinci does have the Iris, although that's not currently available in the UK. They do have their own software, and currently CMR do not. Da Vinci is also very good with their simulation of operative cases. Currently, CMR do not have operative case simulation, and there's no integrated table, which is not really a necessity, but that is not available with CMR Versius. So really, the CMR Versius is still a journey. It's not 20 years in clinical use like the Da Vinci. It's still requiring developments. There's still developments ongoing. Very receptive, the team. I think the procedure to train surgeons and surgical teams is very, very good. I think the governance is very good. And I think it does have a future, especially with respect to cost. But I think it is in development. So those people who are going from Da Vinci to CMR may find that they preferred the Da Vinci because it is a little bit more advanced and it does have more variability in instruments. However, I think that CMR will get there at some point. Some people say it's already there. Those people who are laparoscopic surgeons really, really love it. It's those surgeons, and this is me being really honest, maybe too honest, those surgeons who are used to Da Vinci possibly or probably prefer Da Vinci, but those laparoscopic or open surgeons really do love using this robotic platform. So I'm sorry if I run through that quickly, but I'm aware that you're short for time. So if you can't ask me questions now, please feel free to take my email and get in contact with me that way. But I'm happy to answer questions if we have time.
Thank you very much, Doctor. Very informative, and we were all interested to know the difference between the two systems, robotic systems, and you very informatively elaborated on both of them. So thank you very much again, and we will keep you involved into our future talks. So I really appreciate your time, and thank you all of you. I really appreciate your time and your talk, and it was all very informative. The last session, and thank you very much. And now coming back to the audience, 3 quick activities, sir. Thank you for your patience. Thank you for coming. We have 3 things. We have tea, we have certification, and a group photograph. So I think we'll move towards. Is that okay, sir? Thank you very much.
So I would request